All right, now we're recording. So everything is as it should. All right. So today, is it just the one chapter today on the schedule? Yeah. Okay. Is it? Is it really? Oh, perfect. All right. Let's get into the PowerPoint and see how we do. So it looks like we're covering carbon monoxide poisoning and nerve agent poisoning today. And anatomy, physiology. We obviously cover, poisons can get into the body through several, different ways. Many of us are hazmat gurus, but there's plenty of different ways that poison can get into the body. Inhaled, ingested, injected, absorbed, alcohol, opiate. So this is something that we're going to run across regularly in our treatment of patients and already are. Yeah.
You want the background music on?
Oh yeah, that's good. It might make it more palatable today. All right. So poison is toxic by nature. A drug can have a therapeutic effect if it is given appropriate circumstances and dose. So I guess probably what it's saying is that any drug, even if it's prescribed, can be considered toxic if it's given, if there's too much, if you get into outside that therapeutic range. Everybody understand therapeutic range? Was that covered in pharmacology? I'm assuming it was. There's an area, based on the level of that drug that's available in your body at any given time, you'll have the effect, the toward effect that you're looking for. More or less, you may have untoward effects or side effects. And in this case, they're talking about it being poisonous, something that's going to harm you if it's above that therapeutic range. Toxicology is a study of toxins or toxic or poisonous substances. And then our emergencies are going to revolve around intentional or unintentional. I really wish I would have been able to look through these slides beforehand. I apologize, guys, but because I hate coming to class where they just read slides. I feel like we're going to be doing that a lot today just because I don't know what these slides are, but we're going to do the best we can. So toxins can be found in nature or the workplace, neglect, oversight, intentional, date rape drugs, biological warfare, or we've seen all those instances through different reports or whatnot, where people will they'll, in attempt to harm themselves, they'll have a larger scale chemical issue that goes on that we have to be aware of as first responders. Poison Center is a resource for us. I will admit I've never used the Poison Center. Actually, I take that back. One time did we make a phone call to the Poison Center, and it was for an over-the-counter medication that we were unfamiliar with. Most of the time on scenes, I've just Googled, and you can usually get the toxic ranges. Like if you take this many milligrams, it's going to be toxic. And but in one case, did I have an officer that contacted poison control, and nothing really came from it. They were good help, good resource, and encouraged transport to the hospital. And I wish I could remember what the drug was, but that's why we called them, is because it was something we weren't familiar with, and we didn't. Yes, they will. As far as I know, in that scenario, I think they did. They said if you take X amount of pills, at that point it becomes, lethal if it ever can be. I think most over-the-counter drugs there's not going to be a lethal range, or I guess I shouldn't say they won't be, but it's less likely. But yeah. Absolutely. Kaipo wants to speak for a second.
Can you hear me?
Yes.
Oh, okay. Hold on a sec.
I'll mute us.
All right. The only thing I can speak to is that, definitely on our level, I could see where, without having a medic on scene or in the room, if we're all kind of all alone, I've used it multiple times just because, I realize we just don't know, or maybe in over our heads on a few things. But the crazy thing about calling from our area here is that depending on what cell tower picks up your cell phone, you could either get the Washington poison control or Idaho poison control, and the weirdest thing about that is that that the Washington poison control almost always will defer you to calling the Boise number, and that's a direct number that when you call the general poison control line, that I've actually had the Washington folks say, well, we can't really help you because there's different ways that each drug is managed by different states, so we don't want to tell you the wrong thing to do. And I've actually had to have an argument within the last 6 months with Washington poison control. I said, here's the deal. This child took blood pressure medications, and I just need you to tell me if I need to do something real quick, because I don't want to wait for 5 minutes for you to transfer me to Idaho and whatnot and stuff like that. So just kind of a small little story that kind of affected us. But yeah, I've had to call it more than a few times, and it's actually worked out pretty well. You just call the number, but be prepared in this area to be transferred to the Idaho one.
So the pathophys, routes of absorption, toxins can't have their effects or exert their effects until they enter the human body. And that's usually the only time we really, we shouldn't say the only time we care about them, because obviously the risk of them entering the body is worth noting as well. But toxins enter the body in 4 main ways: ingestion, which is was probably the most common that we come across in EMS, and inhalation, injection, or absorption. Effects and excretion determined by the amount of toxin, and then each toxin will have a different way it's metabolized and how the body metabolizes it. That's why it's important or nice to have something like the Poison Control Center that you can reference, because they'll have all that stuff dialed in. Most common sources is the medications around the home. So whether it's an infant that finds mom's pill bottle that's open and decides to eat them all because they look like candy, or it was intentional or unintentional, medications that are prescribed or available in the home are the most common, or chemicals, especially for toddlers. That's more common. As kids get older, they learn that cleaners aren't delicious. So, but young infants might get into, like the Tide Pods. We hear about that stuff all the time. The Tide Pod challenge. Effects may be immediate or delayed. So, it all depends on what the toxin is. Poisoning by ingestion. So in some, hey Shane, yeah, it looks like are you ready? Are you prepared to roll today?
No.
All right. Have you looked through the slides? I mean, are you at least okay? So poisoning by ingestion, some systems, and one that I first started in actually had activated charcoal as an available medication for us. Has anybody seen that or had access to that before? Have you seen it? You've seen it with your eyes. Awesome. We had a EMT instructor when I was in EMT basic class that said you can't, virtually said you need to try it so that you know what it's like for these poor people that you give it to. And it was horrible. It tasted like dirt, and it made your whole mouth black. It was horrible. So luckily we don't have that now, and it's a adsorbent, so it binds to the poison and carries it out of the system. But that's not something that's in our protocol, and it's kind of going out of favor now. It's not as common as it used to be. ERs will still do it. It's pretty common in the ERs as far as I know, but typically it's in a very acute, ingestion. It's by the time they get to the ER and stuff like that, they aren't given this activated charcoal. Yes, and like Hypo or Kenny, one of the two, is saying, get ready for puke. I mean, they will. There's a likelihood they will puke when they drink that activated charcoal. But again, not something we're going to see in EMS, at least in this system. Inhalation. So some medications, I'm not sure which ones off the top of my head that you would be inhaling or have more, like you'd inhale more than you would, or you'd have a poisoning by inhalation on a medication. But household chemicals is much more common. So when you mix a couple of different chemicals, or you're trying to do something cleaning, you're in the bathroom and you're trying to clean the grout, and you use one thing and then you mix another one because it didn't work. Some of that can really be problematic. What's that? Carbon monoxide, yeah, absolutely. So, and carbon monoxide is considered a poison for what reason, Rusty? Like, what does it do? Yes. Yeah, absolutely. And I'm guessing we're going to talk at quite a good length of that. I'm guessing that's where this is all going. But yeah, so like Rusty said, that carbon monoxide will displace the ability or displace oxygen off the hemoglobin, and it has it binds with a greater affinity to the hemoglobin than oxygen does. So poison by inhalation, it can only occur if the poison is present in the atmosphere, so if it's inhalable, obviously. And then if you suspect that, don't enter the hazardous environment. If you go to a call and there's several people that are having the same symptoms, don't just rush in there to be the rescuer. Be aware that, have that in the back of your mind. And there's always a hazmat team. There's always a hazmat team. In the inhaled toxins, they quickly reach the alveoli. As soon as you breathe it in, one breath. In some of these toxins, one breath will be enough it could be considered or could be fatal because it's so fast. So you got to consider scene safety. You got to make sure you're staying safe. It says take your containers, bottles, and labels with you. So if you don't know what it is, or you know that this person is feeling sick because of this drug, you can take it with you. I'm not a huge fan of that. I would rather you just take a picture or write it down or something like that. That way you're not, taking that toxic substance with you. I mean, I guess if you can contain it completely, that might be okay. But you need to have the information from the scene, and that's the only place you're going to be able to get it is especially if you know that that's the toxin or the what's causing the issue. So treat these patients with oxygen. Treat hypoxia immediately. So poisoning by injection. So this is usually just a drug abuse situation. Signs and symptoms can vary greatly depending on the type of drug that they're injecting or that's being injected. And generally, injecting poisons are impossible to dilute. Quickly absorbed because it goes right into the bloodstream. It makes sense. In these patients, I would say that, like I said the other day, the solution to pollution is dilution. So this would be a situation where maybe some high flow or high volume fluids would be appropriate to try and dissolve some of that or disperse or thin out some of that toxin. Poisoning by absorption. So the most serious absorption poisons are pesticides. We have farmland around here. There's a good chance that this is a call that we could go on in this area where somebody comes in contact with a fertilizer or pesticide, and whether it's splashed on them, spilled on them, or brushed on them with a dry substance, it can be corrosive, damage the skin, mucous membrane, eyes. Distinguish between contact burns and contact absorptions. Any ideas what that would be?
I think what they're just trying to find is figure out, is a contact burn versus absorption. I want to so if it's a dust or powder, so, you know, getting that off there, I would say it's more their signature and timeline.
Sure. So like Shane just said on that, just they're, you know, identify the timeline, how recent. By absorption, the signs and symptoms, so the history, so did they come in contact with, was it a liquid, was it a powder, you know, is it burning, is it not burning, can you stop the burning, itching, irritation, skin discoloration, the typical odor and substance. And most of the people who are going to have these symptoms are going to know what is going on. Like they've been taught, or they know, or they have a friend, or a, like for example, my father-in-law is a farmer, and he can tell me story after story after story how this person was this pesticide because it's there. That's what they talk about when they get together for lunch, right? So you know, they will probably or likely be educated. The times that you won't be is if, you know, a child gets involved, you know, and they just see that these jugs and they look like fun, or these paint buckets, or these 5-gallon pails, or this bag, or whatever opens up. So it's not always the case, but oftentimes they'll know exactly what's going on, or can tell you. So so you want to avoid contaminating others. So remember your PPE, isolate this patient from other people, remove the substance from the patient. So and cut off contaminated clothing, and irrigate the contact area with water. So I would say this. So I've been told in the past, and I'm not sure why, and this is just me talking, I'm not sure what your book says, but if it's a powder, you want to brush it off. Don't rinse it off. I don't know if your book is telling you that or not, but try and brush it off as best you can, and then flush the area, because it may be reacting to water. And unless you can rule that out, or you know that for sure based on the label, or somebody telling you that's educated on it, not just hopefully, but they really know what's going on, you want to brush that powder off the best you can before you start irrigating.
Kind of to go along with Pete on the brushing it off, think about when you guys are reconstituting medications. So we reconstitute glucagon. And with glucagon, it's powder form, and then we put a saline on it, or solution, and then it makes it more potent. So when you guys are thinking about this, you know, have that in your mind, that when you put water of these, you're going to reconstitute, but you might make it even more potent. So things to consider. So we try to lessen the blow by getting rid of as much as we can, and then try to dilute it.
Perfect. Thanks, Shane. So understanding and using Toxidromes. So Toxidrome is the symptoms that point you into the direction of what substance is causing the issue, if that makes sense. So I guess it says here, syndrome-like symptoms of poisonous agents. So certain poisons will create a syndrome, or they'll, you know, like you've heard the acronym sludge, like they'll do that type of stuff. So that's a toxidrome. Many of the drugs result in similar signs and symptoms. They're either natural or synthetic. And so major toxidromes, so, you know, these are grouped together. You know, toxidromes can be a stimulant, they can be a narcotic, they can be a sympathomimetic, a sedative, a hypnotic, cholinergics, anticholinergics. These are all the different groups that these drugs can fit in based on their toxidromes. All right, so substance abuse. So this area of medicine is challenging, and I would agree with that. I mean, there's a whole behavioral health wing over at Kootenai Health addressing things like substance abuse. And in the acute setting, not even like long-term, you know, how do you manage somebody that has, you know, frequent substance abuse with poisons or with drugs that create a poison? Cultural variation in what is considered substance abuse. So I guess that's saying that in some, you know, maybe in, I have no idea. I guess there's a cultural basis, you know, in some cultures, some things are more accepted than in other cultures. So that can have a basis or a variation. And society's definition may be have little relation to potential harm of substance. So what's acceptable by society doesn't necessarily mean that that's acceptable like to your body. So it can still be harm or potentially harmful to your body, even though society may say it's fine. Substance abuse terms. So habituation, physical dependence, psychological dependence, tolerance, withdrawals, drug addiction, antagonist, potentiation, synergism. I'm assuming we'll probably go through a lot of these. Oh, scene size up. I didn't even look to see how many slides were in this. Seriously?
Yeah.
Oh, man.
Some words I didn't know. Can we go back to synergism? One big thing about synergism is you'll actually experience, medics will experience, when we put too many benzos on board, and you actually, if you have a COPD and you're breathing them and you decide to sedate them and slow them down, you can create this effect and we'll put them in this hypnotic state, which actually will drop their blood pressure and pulse, and eventually they will code on you. So you can cause these type of effects just by you trying to treat the patient. I know we're talking about substance abuse, but some of these things we can do as medics and EMT advances to put these people into these type of issues. So just FYI, if you think about withdrawal syndrome, say a heroin addict goes all the time, we decide, for pain, an old lady that has pain management issues all the time, we give her a little Narcan because we think, we want to wake her up a little bit. Now you just withdraw her narcotics and you put her into this withdrawal system. So there's a lot of things we can do that could devastate our patients. So we got to think of these things. Does that make sense?
Absolutely. So scene size up. So you got to determine your NOI, how many patients are involved. If you have multiple patients, you should be really thinking about what's going on here. You got to make sure your scene is safe. On a drug overdose, even if it's one patient, PD is usually involved. You got to make sure that PD's got the scene controlled. It knows what's going on in the scene. You need additional resources, whether that's making sure PD's coming. If you got to wait for county to show up, make sure you're doing that. Unconscious patients, you should always consider spinal immobilization and make sure you're wearing your PPE. And patients are going to be potentially unpredictable. So be aware of that. Patients may be dangerous. So look for your clues, empty or even open or available medication bottles, alcoholic or alcohol beverage containers, syringes, drug paraphernalia, weird odors, known history of, like certain locations or certain, certain houses have, that stigmatism attached to them where they're like, oh, that's that house. We go there all the time. So just be aware of that stuff. General impression, life threats. This is all the normal stuff. Airway breathing, circulation. These are all, we should be starting our assessments the same every time through ABCs. Circulatory status, skin condition, check for bleeding. If they're unconscious, consider C-spine. Obvious alterations in the ABCDEs or poor general impression require immediate transport. Definitely require some immediate interventions. A delay on scene is rarely indicated. And then just depending on what's the source of the toxin or the source of the poison, you may want to do a decon before you even move the patient to your ambulance, because now you're moving a hazmat scene. Now you're driving down the road, moving a hazmat scene to another location. Obtain history, get a sample, and then get whatever information is available if they're unresponsive. This is all pretty self-explanatory. So you want to find on your history, you want to find what your agent is, if at all possible. Contact poison control if you need to. When, time frames are important. When was it absorbed? When was it ingested? When was it injected? And how much? What else was taken? Was there, because there's other things, some people will, they maybe, they have access to Google the same way we do, right? So they may know that their SSRI medication isn't going to be lethal in this dose by itself, but if they mix it with this other drug, then it becomes a respiratory depressant and it's going to be lethal. So, think about what else might have been taken. Has there been any interventions performed? Has the patient vomited? Weight and then intent. Why was the substance taken, or what happened? What led him to this situation? Secondary assessment. So you can focus on the area of the body involved. If the poison is absorbed, focus on getting that spot managed, whether it's on their arm or torso, whatever. Baseline vitals. Ongoing assessment is, look for alterations in the level of consciousness. Are they trending one way or another? Unless you're doing something to reverse, there's a likelihood these patients are going to continue to deteriorate. You might have a patient who took a bunch of prescribed meds, and they're talking to you when you're on scene. You start transporting, and they start getting groggy and lethargic, and now they're bradycardic, and now they're hypotensive. So be prepared for those changes. Reassess your ABCs, evaluate your interventions, repeat the assessment of vital signs every 15 minutes for a stable patient, every 5 minutes for an unstable or somebody who's consumed a harmful or lethal dose, even if they look like they're currently stable. They will change on you fast. Support the ABCs, most important. Dilute the airborne exposures with oxygen. So if it's something they inhale, just feed them a bunch of oxygen. Remove the contact exposure. Like I said, if it's powder, brush it off. If it's something liquid, rinse it off. Consider activated charcoal, which we don't have. So and then contact medical control or poison center for treatment options. Most of these in your scope, most of these patients are going to be treated with. You have one drug available to you if they're unconscious. What is that? Anyone? Yeah, so it's Narcan, right? Intranasal Narcan. I think actually in the advanced setting, it's even available to you at IV. But Narcan if it's an unconscious with a suspected opiate overdose. And then other than that, high flow, or you're getting a lot of volume of IV fluids. Just try and get as much information as you possibly can about the poison. Take the pill bottle with you. Take a picture of the whatever. So just so that you can inform, because this patient's going to be treated over a long period of time. So as much information as you can take, the better. Material safety data sheet. If you're in a place that would have that, grab that. Those should all be available in most of our big commercial businesses. So emergency medical care, I feel like we kind of just covered some of this. So remove the tablets or fragments from the patient's mouth. So I guess if they still have something in their mouth, remove it. I mean, that's part of assessing the airway. Wash or brush the poison from the patient's skin. We've hit on that. Assess the ABCs, provide oxygen, treat shock with the IV fluid. Again, according to the book, you give activated charcoal, so I'm guessing that might be a question you might have to answer down the road, but in our system, we don't do that. Activated charcoal is not indicated for people who have ingested an acid, an alkali, or petroleum product, or who have a decreased level of consciousness. So if they can't protect their own airway, don't give it to them. And if they're not able to swallow, don't make them drink something they can't swallow. Side effects, black stools, vomiting, nausea, possible airway problems. I'm guessing that's from the vomiting. So alcohol, most widely abused drug in the U.S. So alcoholism is a state of physical and psychological addiction. So alcoholics tend to have chronic malnutrition and fall frequently. I think we've all seen this. Somebody who's constantly what we'd consider an alcoholic are frequent flyers that we see regularly that, and it doesn't have to be a frequent flyer. We can have one time where they get bad enough that a family or somebody checks on them and say, all right, call 911, and here we are. But getting a history is going to be a big part of that, to find out, are they taking care of themselves? Do they have somebody that's living with them? Things like that. Fourth leading cause of death in the United States. I didn't know that. That's pretty high up there. Alcohol is a CNS depressant. I think we all know that. It decreases activity, excitement, induces sleep. It dulls a sense of awareness. It causes aggressive and inappropriate behavior and lack of coordination. What's that?
Everyone who's been through their 20s.
Yes, exactly. So we should probably have a lot of conversation about alcohol. There's probably very few people that know. Anyway, regardless. So medical problems associated with alcoholism. So, these people are potentially could fall a lot. So look for trauma, especially head injuries. Head injury can be disguised by, being intoxicated, and vice versa. The respiratory depression, aspiration of vomitus, physical dependence. So they may have a very significant withdrawal syndrome if they stop taking or stop having alcohol. And that's an emergency. That is an emergent situation. That is an illness. Hepatitis, cirrhosis, so it's just damage of the liver in one shape or another. Consider internal bleeding. A patient appears to be in shock. So why? Anybody know enough about alcoholism to know where you'd be bleeding? Where? But even like abdominal.
Oh yeah, you get varices.
Yeah, so esophageal varices it can be common in these patients because they're constantly drinking and it's constantly eating away at their esophagus, and their veins that are running right along with your esophagus can be damaged. And so if you have a patient who's puking just like a tremendous amount of blood, that just constantly, and they have a history of alcoholism, suspect esophageal varices. And that could be like more blood than you can manage coming out of somebody's mouth. I mean, it can be pretty ugly. I've only seen it once. It was pretty ugly. Stomach, yes, absolutely. I mean, you could be eating away at the stomach. It could be anywhere in the body really, but the esophageal varices can pose a huge challenge to your ABCs in all three actually. So. Withdrawal symptoms include seizures. They'll have the delirium tremors, but they'll also can have full-blown legitimate seizures. If patient exhibits signs of delirium tremens, so you just keep the patient calm, give them oxygen, manage their hypotension, and maintain a dialogue. Just continue to talk to them, reassure them, let them know you're getting them the help they need.
Just know in varices, you won't have hypotension, you don't have hypertension. The difference. So usually patients with hypertension are more prone to varices. So something to think about.
Excellent. Narcotics, opiates, and opioids. So a narcotic is a drug that produces sleep or altered mental status. Opiate is a natural drug derived from opium, and opioid is a non-opium derived synthetic. So examples: morphine, codeine, heroin, fentanyl, oxycodone, meperidine, and then the other two that I'm not going to pronounce. Those are just examples. There's plenty of them out there. There's tons out there. And they all have different types of names, and some of them will have a street name. Some of them will have a legitimate generic name. It's, brand names. There's all sorts of different things. These can be prescribed. They can be available on the street as an illegal drug. There's all sorts of, these are prevalent throughout society in a number of different forms. So, even fentanyl, you can even go on the patient at your local life care center and have an altered mentation. And are we doing a job of, looking at their back, because they could be, have a fentanyl patch even. So, I've even seen one scenario out at the truck stop where somebody was chewing on fentanyl patches. They had it rolled up and it was in their mouth like a chew, and just weird stuff. So that was when I was asking where the bleeding could come from. Narcotics, opiates, opioids bind with the receptor site in the brain and other tissues. So they're absorbed through the GI tract, nasal mucosa, or lungs. So, I mean, there's a bunch of different ways you can take them: orally, a nasal, nasally, or inhalation. When heroin passes through the liver, it continues to exert narcotic effects that may outlast effects of Narcan. So this is something I don't think we talk about that often. I think we give Narcan, or even, not I should say even worse, but sometimes even PD gets on scene beforehand. They give them 4 milligrams of Narcan intranasally. When by the time we get there, they're alert, conscious and alert, GCS 15. They know exactly what's going on, and they're refusing transport. But this aspect of heroin is often overlooked, where we should be strongly encouraging that these patients get to the ER, because the heroin can outlast the Narcan. Are there significant amount of cases where that happens? No, but it's a possibility depending on how much heroin they have, their tolerance, their ability for their body to metabolize that. So do they always, and this is just Pete talking, but do they always have to go by ambulance? No. I would say that sometimes it's appropriate to have PD, but PD, we should be having that conversation with PD. If this person's in custody, they need to go to the ER first before they go anywhere else. So last thing I want to do is put them in a jail cell and hours later check on him and he's overdosed again. Morphine and heroin produce an impressive dreamlike state, which is probably why people take it. Presentation, euphoria, hypotension, respiratory depression, pinpoint pupils, vomiting, coma, seizures. So these are the telltale for us is the pinpoint pupils. We are almost always assessing for that to identify whether or not it's a heroin overdose. And then we're usually given Narcan because of the respiratory depression, right? We're not just trying to wake them up. We're trying to reverse the respiratory depression is the reason why we give Narcan. Here's a algorithm for you that we're not going to get into. I'm sure it's available to you in your books. So Narcan reverses the effects of the opiate. So it binds to those receptor sites. So that opiate being able to bind to that site, Narcan, and has a greater affinity for that site. So it displaces the opiate that's site, and Narcan binds there, and it just hangs out and hangs out and hangs out. So Narcan can be administered via IV line or intramuscularly, or my favorite is intranasally. I've had great success with this. I know I've talked to some medics and they're like, I've never had success with intranasal. I don't ever give it. I don't like it. I've had great success with intranasal because it's something I can get on board really quick. I don't have to wait for an IV line and whatnot. Am I working on an IV line if they're unconscious? Yeah, there's a lot of other things that are going on, but it's a way that I can just get the Narcan on board intranasally, and then while I'm doing all these other things, and then I'll know whether or not it's effective by the time that we have to make decisions like how do we protect this patient's airway. Just be aware for vomiting after you give Narcan. Monitor patient closely and transport promptly. So stimulants, so they can be swallowed, smoked, IV injection. I think there's probably other ways that you probably take a stimulant. Clinical presentation is excitement and delirium, tachycardia, hyper or hypotension with a fast pulse, dilated pupils, tremors and seizures. So, these are the patients we go on and they're acting crazy, and it's taken 3 cops to subdue a 20-year-old, 98-pound female, because she's on meth and she is, having all these symptoms. And, are we doing our best to evaluate that patient and get down to the bottom of it and figure out what's going on? Cocaine, local anesthetic, CNS stimulant, quickly absorbed.
Remember that last slide? The very thing that one assessment tool we forgot is they'll be overheated. So we also got to make sure to get temperatures. If you guys took Ed Minster's lecture, he talked about treating the temperature. So that should be part of our assessment tool too, to not overlook that stuff.
Oh, that's good. It's good point. Yeah, these patients will be very warm potentially. Often with cocaine, you'll have a crash afterwards. Amphetamines. So.
Can I speak on the
Absolutely.
Yeah. So, and my experience with cocaine, not personally, but when I was in Spokane, we had a lot of cocaine abusers, and that crash, we called it in the field cocaine washout. And what that would do is these guys would go on these benders, like 6 to 10 day cocaine benders, to where they were partying, and they hit that peak, and they'd start that therapeutic level, and they would start to dive down, and they couldn't get any more cocaine. So what they would do, they offset it with alcohol or whatever they can get their hands on, and then basically puts it, what we call it, a cocaine coma. And they would go into these comas for like 3-4 days at the hospital. They come out of it, they get the fluids, the things they need from the doctors, they get up and then just leave, like nothing ever happened. So these ones are tough because when you are in that cocaine crash or the cocaine coma, those are the ones that, I mean, they usually respiratory arrest, and those are the bad ones.
Okay.
Just FYI, they can go extremely fast where they're chaotic into a coma.
Yeah. And I probably haven't seen it to that extreme. Shane's seen it in Spokane, but I have seen it where they're super lethargic. It almost looks like heroin, like they're just almost unconscious, super lethargic. And then, you know, we're told constantly, well, that all they do is cocaine, or that's all they've done. And you're like, this isn't adding up. Like, well, when was the last time they took it? Well, it was yesterday. Okay, well, that's starting to make sense. There's a big crash afterwards. So, amphetamines. So some people are prescribed an amphetamine for, you know, a number of different reasons. So there are some legitimate uses for amphetamines, but a methamphetamine is low cost, long acting, extremely addictive, and it's, you know, I don't think it's as prevalent as it was, you know, a decade ago, but it's still, we see this all the time in EMS. And meth labs they're hazmat scenes. Those are not something that we should be treating lightly if we've come across something like that. Synthetic cathinones? Any idea what that is?
That's just basically.
So is that like Sudafed, and that's all the?
Yeah.
So that's.
Over the counter stuff.
So I know that, I mean, I shouldn't say I know, but I've heard that stuff is used to make meth. But I didn't know it's independently. So signs and symptoms, it's just more. It's a stimulant. So wild-eyed.
They're just saying that it's just man-made. They basically take a bunch of chemicals, they make it in man-made, and then they grab whatever they can.
I think these signs and symptoms are common, not just with this, but I mean, I've seen it with meth as well. As you know, they're usually pretty thin, you know, but aside from that, they're also like nervous and they're jittery, and they think that something's, you know, potentially going to get them there. They have a paranoia about them. So that's all signs of a stimulant that's being abused. So the complications, you know, they could have an MI. That's very possible. Their heart, it increases the cardiac workload tremendously. They're constantly in a state of tachycardia. Seizures, stroke, apnea, hyperthermia. Like Shane was saying, the heat thing is a big deal. So Kaipo, are you saying that cathinones is a salt? Is like bath salts? Sweet. So, yep. Okay, well, that helps. I didn't know what a cathinone was, but I know what bath salts are. I have not been on a call where bath salts have been abused, so I can't really speak to what that scene or what that would have looked like, but it seems very similar to what meth would look like. So the treatment, oxygen, you know, ABCs, manage your ABCs, prevent seizures with adequate sedation. So if they're seizing, I mean, having a benzo is acceptable. Serial vital signs, IV access, manage hypotension. I think fluid is very indicated on these patients. Pulse ox. Consider paramedic backup. Medic! Backup! I need backup! Have you seen that fire scene where they're... Oh, never mind. I won't go into that. Marijuana, cannabis. So usually smoked with effects in minutes. Smoking marijuana results in bronchodilation and slight tachycardia. Other symptoms: euphoria, drowsiness, motor coordination or diminished motor coordination, and bloodshot eyes. Management focuses on supportive care. Probably most of the time that we'll run across this is in the synthetic marijuana. Seemed like a couple years ago, there was several calls that were running on where there was a synthetic marijuana that was going around, and it was very similar. These were their symptoms, but they weren't smoking, so it was very, history was tough to get a history of what was going on, but they had these symptoms. Hallucinogens, so it alters your sensory perception. LSD, PCP, ketamine. So these are all hallucinogens. Treatment is primarily supportive, limit the sensory stimulation, routine transport plus psychological support. PCP and ketamine users, they're, oxygen, IV access. Most of these are going to be, in my opinion, they're going to be IV access and start diluting their toxic condition. You're managing all this other signs and symptoms, the ABCs and things like that, obviously, in these patients, but sedatives reduce anxiety. Hypnotics produce drowsiness and sleep. Sedative hypnotic drugs function as CNS depressants, so like a barbiturate or benzo. Guess I remember hearing that, but I've never seen it in pre-hospital. But a barbiturate user will develop a tolerance, require larger doses. Treatment, very much the same: airway management, paramedic backup, high flow O2, IV, and managed shock. Cardiac medications, so there's antidysrhythmics, beta blockers, calcium channel blockers, cardiac glycosides, angiotensin converting enzyme inhibitors, and many patients take several of these, different combinations of. And they, like we were talking about earlier, even these drugs can be considered poisonous if taken in the wrong dose. So signs of overdose, depending on which one you're giving, but technically typically they'll all result in the same types of symptoms. Any type of overdose of those cardiac drugs: hypotension, weakness. I'm not sure. Well, I guess rhythm disturbances. Like if you overdose on beta blockers, if there's too many beta blockers, they're going to be bradycardic and hypotensive. Nausea, vomiting, headache, difficulty breathing. Getting a history on these patients, figuring out, are they taking their medications as prescribed? Who's giving them? Are we at life care where a nurse is responsible for giving them their medications? Was there a shift exchanged? Was it documented properly? Did they get a double dose when they shouldn't have? Things like that. Ensure a patent airway. So ABCs, just like always: Mr. High Flow Oxygen, IV access. Yes, if you want, you can contact medical control. Erectile dysfunction medications are the most dangerous of various drugs that increase sexual gratification. All right. And tricyclic antidepressants, TCAs, carry a high risk of intentional overdose. So the side effects of TCAs can be very addictive. So, that's a possibility that people, if they're prescribed a TCA, they'll take, and they'll start, they'll start increasing their dose on their own to the point where and they'll keep going and keep going and keep going until they find themselves in a poisonous situation. They're above that therapeutic range. So, but these are going to be the same way: ABCs and IV access, manage hypotension. Sounds very familiar. MAOIs, they can precipitate a hypertensive crisis if taken with a tyramine-containing food. I'm not even sure what that would be. I apologize. Early signs and symptoms include hyperactivity, dysrhythmias, hyperventilation, nystagmus. So overdose on an MAOIs would be similar to a stimulant in some ways. no antidote available. ABCs, and activated charcoal if it's in your protocol. SSRIs, so they're selective serotonin reuptake inhibitors, so this is an antidepressant as well and a different variation. It's a widely, very common drug. I mean, there's tons and tons of these that are prescribed. Be familiar with the names of them. I can't think of any of them off the top of my head right now, but be familiar so that you can recognize them. And the patients may be asymptomatic, so these are the patients that are going to it's going to lull you into a sense of comfortability, and then they're going to crash on you fairly quick if they have a high level in their blood. Plus, these are the ones that you have to worry about, in my opinion, where I've seen more times where they take a polypharm, where maybe they've intentionally overdosed on these before. They realized it didn't work the way they wanted it to, and so now they're mixing other things to go with it. So, like I said, they have access to Google too. ABCs, high flow oxygen, IV access. Lithium. So this is a common drug prescribed for bipolar disorder. And I don't know that I've seen this prescribed too many or very many times, but it is out there. Signs and symptoms: nausea, vomiting, tremors, thirst, slurred speech. ABCs, high flow oxygen, IV access. Yeah, true. NSAIDs. So NSAIDs are like aspirin or Aleve. There's a bunch of them out there. They're prescription strength, the ones that are very common that get prescribed to people all the time. Most of the problems associated with these are over long-term use. Headache, altered mentation. These are going to be, maybe they'll have abdominal pain. Again, it can be ABCs and IV access. Salicylates, yeah. Over-the-counter products containing salicylates cause toxicity. I'm not sure even what, off the top of my head, what over-the-counter medication. Who's got Google at their disposal? Is it? I don't think it's aspirin, is it? Is it? Oh, all right. Okay. Perfect. I think we have somebody smart here. All right. Some supportive field management, and then acetaminophen, so Tylenol. So few side effects. There is toxic doses. Most of the toxic effects are going to be felt with abuse over a long period of time.
When you think of aspirin, you think of Tylenol. These are the tough overdoses that we go on. The big thing we should be is establishing a timeline. But the tough part is we have to get a good history on these patients that take these medications, because ultimately, though we won't see huge effects of we need to start crushing their vitals and stuff, what we need to do is long-term, like their liver failure. So we're going to have to look at these patients long-term. These are the ones, the overdoses and stuff, they have a long road ahead of them. It's going to be a painful road. And so trying to get these, getting a good timeline, setting up yourself, and then giving the doctor the appropriate amount of how much you got to think of a toxic level. Does anyone know the toxic level of Tylenol? I want to say it's 26,000 milligrams. It's up there, right? But I mean, you look at Tylenol, it comes in 500 milligram form. So I mean, you can, a handful of that could get up into that toxic level. So
I will tell you where I've seen Tylenol overdose more is on kids, because they flavor their medicine and they're like, oh, it's grape, it's delicious, the cap's not on, whatever, it's left out, and they just drink it like it's Kool-Aid or whatever. And so I've transported a few kiddos because of that. So
he brings up a great point, especially with kids. When new parents and stuff, the doctor will hand them a sheet that says, your kid weighs this, give them 5 mLs, 2.5 mLs. So make sure that the family, when you decide to leave the kid at home because he's got a fever, make sure they're dosing their kid correctly, because they might not know it, thinking, oh, this is 2.5, is what I give, but they said 2.5 milligrams. It's a different dose. So make sure they understand what you're given. I've sit there and taught a lot of families, so make sure they're not overdosing the child, and you're okay with that. So please think about it.
Yeah, we should take those opportunities to do a little community education. Right, Scott? Right. What's that? Oh. I'm not even going to try and say that. GHB. Frequently associated with sexual assault. So I think this is the date rape jug. Right? Shane, you're like emphatic mainly? Yes.
It's we call it Molly now.
Molly? Okay, perfect. So pronounced hypnotic effect. So disinhibition. So they're, lowers their inhibition, severe passivity, and antegrade amnesia. So some of these, if you run across a call where you suspect this, they may not even know or have a memory of what happened over the last period of time. And so we need to be suspecting that there might be a sexual assault involved and handle that as well. So treatment focuses on the CNS depression and the risk associated with the patient being able to protect the airway. So, ABCs, IV access, supplemental oxygen, kind of a repeat. So organophosphates. So these are like insecticides or nerve gas. So these are going to be most common in agricultural accidents or suicide attempts. We shouldn't be running across too many of these just in that general home, if you will, but you get called out to some weird and allergic reaction out on the farm. You should, hopefully on the way you're thinking, all right, what are my rule outs? Signs and symptoms: anxiety, restlessness, headache, dizziness, confusion, tremors, seizures, dyspnea, respiratory depression. So there's a couple of acronyms or mnemonics, I guess, that will help you identify organophosphate. So sludge, EM, or dumbbells. So see if I can remember what the sludge: salivation, lacrimation, urination, defecation. You're going so well, Shane. GI, it's like a GI upset or something like that. What? Emesis? What's the M? What's the M? Muscle twitching. Okay. So be familiar with that. I will, obviously, as you can see, I didn't recall those off the top of my head, but I know that what that means virtually is that the whole body is just expelling everything, whether it's salivating, urinating, defecating. I just think sludge is that means they're just expelling, everything is expelling in every direction. And so to be familiar with that. If I do recall, there was questions on organophosphate in my national registry. There was questions on that in mine years ago. So
I'd focus on blood pressure and vital
signs. Treatment: decontaminate before initiating care. So you got to make sure you're seeing safe. ABCs, high flow oxygen, IV access, call for backup, pulse ox, and immediate transport. I would definitely make sure that your receiving hospital knows that you're bringing in a suspected organophosphate patient. All right, carbon monoxide, so CO poisoning. So it is one of the most common fatal poisonings, especially in the winter we see these more often because people use alternate forms of heat for different situations. Carbon monoxide is colorless, odorless, tasteless gas, and carbon monoxide prevents red blood cells from carrying oxygen, like we talked about earlier. So it's difficult to identify in the field. We have tools available to us now. The RAD57 or the Massimo device, part of our monitors now, are a great tool. But these patients will also have signs and symptoms that we can kind of point us in this direction. So if you suspect carbon monoxide, remove the patient from the exposure. So take them out of the house or take them out of the garage, wherever they might be. maintain an airway, so ABCs, high flow oxygen. Even if these patients are satting at 99% or 100%, you still want to give them high flow oxygen because your pulse ox is reading your, like, how full the hemoglobin is. It doesn't know that it's filled by carbon monoxide or whether it's filled by oxygen. So these patients could still be hypoxic even though your pulse ox says 99 or 100. IV access, keep patient quiet. I'm not sure why. Like, no, you can't talk. That seems a little weird. Is there anything in the book why that is, Rusty? No. Monitor your level of consciousness, transport to the appropriate facility, and consider your possibility to combine CO cyanide poisoning. So let's talk about the appropriate facility. So some of these patients, if they have elevated carbon monoxide in their blood at a certain level, and I can't remember what it is off the top of my head, but it may be indicated to go to a hyperbaric chamber. And nearest hyperbaric chambers, and it's on the valley. It's in Spokane at Deaconess, right?
What I've heard, just in news talking that QP can do it, that they offer it, but you can schedule it. So
So it's not for an emergency situation?
It's not for emergency, but you can schedule it if you have that capability. But Valley, there's a private one right by Valley Hospital. They do it, and then Deaconess was the only one. And I've heard that they no longer. They had the 4 individual beds at Deaconess, but I've heard that they take it by case basis.
So, I would say in these situations, I wouldn't drive past Kootenai Health to go to Deaconess, hoping that you can get these patients into a hyperbaric chamber. I would definitely early call into the hospital and letting them know you have a suspected carbon monoxide. Especially with our Rad 57s, we can even, or our Massimo devices, we can tell them what the readings are, and let them know, and just say, hey, and they may divert you to, but I will tell you in the conversations of the past, it's, take them over there. They can maintain stabilize the patient, and then they will determine whether or not to get them over to hyperbaric chamber or not. So
I can tell you on the last CO poisoning I was in Coeur d'Alene, on station 4, and innovative patient got going and stuff, and I mean, it took some time to set up, but they have to do a lot of stuff. They have to draw labs, kind of stuff. So they're trying to see where his toxic level. Speaking of the toxic level, I want to say it's 25% is when they start considering hyperbaric. So 25% of the blood is CO. So, I mean, that to me seems kind of low, but minimizing oxygen demand, keep it quiet.
yeah. Perfect. All right, so moving on to metals. So lead. I'm not sure where we'd find like an acute lead poisoning in EMS, so I'm not sure. But I mean, look into your book, figure out why this is. Like, figure out the points that you need to know. But I'm guessing treatment is going to be more supportive pre-hospital than anything. Iron's probably the same.
Lead is just the police officers, right?
Yeah, usually associated with trauma from the lead entering their body. All right, so miscellaneous. So chlorine gas. So where do we have a high concentration of chlorine gas in our first due? Anyone? Huh? Kaipo knows, right? Cisco. So perfect. So so there are concentrations of chlorine gas in several areas, and there's other ones too. There's one I think at the sewer treatment plant. I think we went on a cyanide alarm there at one point. But hopefully we're finding and identifying those things in pre-plans and our pre-plan inspections. But that is a risk, and it's going to be if there's a chlorine gas leak at Cisco, there's a risk that there's going to be several people affected. So these are their symptoms: sensation, burning sensation, 1-ton cylinders at the poop plants. So cyanide, fire, industrial exposure, altered mental state, and caustics. So
Water treatment plant has these
yes, cyanide.
gases, what
Yep. Yep. Big. And there should be, I mean, they should be protected with systems for alerting. And I think the one time I went on a chlorine gas leak at the poo plant, we staged, the slab in, and I mean, distance away. It was a very slow, methodical process going through the whole thing. And luckily there wasn't anybody in the hazardous environment, but it did, start, how would we handle this? What is the symptoms? How can we enter? What, all that stuff. So, all right. Methyl alcohol and ethanol glycol. So dry gases, antifreeze products. So they'll breathing fast. So tachypnea, blindness, renal failure, hydrocarbons, like household products.
Methyl alcohol probably racetrack.
That's where I guess, but I don't know for sure. And a lot of these things, I mean, again, are we expected to know? But if we're going to a racetrack for, several people who are having the same symptoms, and you're going for, I mean, we should hopefully be doing a lot of research on the way and kind of slow rolling into those scenes, and just making sure that we're safe, and then doing the research. And, aside from managing ABCs, a lot of these patients aren't going to need, to put somebody on, hey, I need you to Google this right here. I mean, there's no way you're going to know all the different compounds, all the different things that are out there. So. Food poisoning. It's weird that it's in here, but okay. When 2 or more people are sick at the same time at the same scene, often in restaurants, cafeterias. Salmonella, listeria, toxoplasma. Food poisoning. Watch out for it. It'll get you. Abdominal pain, nausea, vomiting, diarrhea. ABCs.
The latest was the salad, right?
E. coli my favorite is, we go, especially early in the year, everybody wants to believe that they don't have the stomach flu. So I'm sure it's just food poisoning. But they're they're hyperthermic, they have temp, and nobody else that's eating the same stuff is sick. And you're like, sorry to tell you, but you got the stomach bug, not food poisoning. But poisonous plants. So there are some poisonous plants. I don't even know if we have poisonous plants around here. Do we have poison ivy? And I honestly have no idea. We do? Rusty says we do, so we must. He must in these parts. So deaths are rare. I have no idea. So watch out for castor beans and Dieffenbachia. Some weird stuff. So good history is going to help you a lot in these scenarios. What's that?
Castor beans produce ricin, right?
Why are you asking me? I don't know.
I just remember that's a weird thing I remember.
That is obscure. Well, look at all those pretty plants. Watch out. Don't eat any of that stuff.
That's gonna be on your test.
Oh, more poisonous plants. We should do a little label match, draw which one is which. Sounds like fun. Whew, that was painful. Let's take a couple minute break. 5 minutes.
That's okay. Are they looking at me? No, it's just weird. Is there a way to get that out of the way? There we go. Do I have a clicker? All right, hopefully the 5 minutes. Sorry guys, I was late. I had, light duty stuff to do, doctor's appointments. But thanks Pete for filling in. Appreciate it. So hopefully everyone's here. We'll just start. So psychiatric emergencies. I think we've all been to these type of emergencies. We've experienced
and probably have a lot of great stories to talk about. These are usually the ones we talk about for weeks. So we'll get right into it. So the National EMS Education Standard Competencies, medicine. So it applies fundamental knowledge to provide basic and selected advanced emergency care and assessment findings for an actual ill patient. These are just kind of like the set standards. So the set medicine, and now we're into psychiatric. So the psychiatric, the region of, it's behaviors that pose a risk to the EMT patient and others, the assessment of management, basic principles of health system, suicidal, and agitated delirium. So again, I feel like these are just basically overviews of what type of patients we go on. So let's get right into the introduction. So we deal with all types of patients. We deal with all different types of personalities. Most people can go to a certain type of patient and know right away they have this medical condition, they have this mental illness, they're on some sort of substances or just stress. I know, like usually when I go on calls and stuff, I can ping it because we've already experienced these type of crises and stuff. It's important. What I like to think about when I'm dealing with these patients is use your gut feeling. If you have a different type of feeling, make sure to use those thoughts. Let's see. Myth and reality. Everyone experiences emotional crisis at some point. I can honestly tell you, I've had basically a panic attack. I thought I would never say that, but it's one of those things where when you're going through a point in your life and you're unsure how to deal with it, body just shuts down and resets. And it's kind of one of those things to know what you need to stand and know how to feel. A lot of these patients, the reason why they're calling 911 and stuff is because they need that outlet. So you as a provider have to understand that though it might be minimum to you, it's a big deal to them. So understand, how they're feeling and what they're experiencing, and then point them to the right treatment path is going to be your best bet. Defining behavioral emergencies. Behavioral is what you can see a person's response to the environment. So responses can be obvious or unclear. I can honestly tell you, when you go on these behavioral emergencies, sometimes you might not see the elephant in the room, and another person might see the elephant in the room. So this is where teamwork, we're all on the same crew, we're all on the same team. I might not be the best person for this hysterical drunk. Scott might be the guy to talk. He's the drunk whisperer. So, using the people around you and your crew and looking for the abnormal behavior. A behavioral crisis or emergency is a reaction to the events that interfere with activities in daily living. Again, there's some people that just live in that behavior, in that crisis. They enjoy it, they live off it, and they like to call 911. The important thing is to be upfront, honest, and get them directed and don't play into their crisis. Magnitude of mental health problems. Again, I feel living in the inland Northwest, I feel like we have a high rate of mental illness. We have a lot of mental illness come from Spokane into these areas and stuff. And I feel overall, as Kootenai Fire, I'm speaking just for Kootenai County itself, I feel we have kind of a poor outlook for the mental health disease. I don't think we have the funding and that kind of thing to move these. I think we kind of shelve them to Spokane or try to do the best with what we have. According to the National Institute of Mental Health, 1 of 5 Americans has some type of mental disorder. So if there's 5 of you in the room, figure out which one it is. Mo, you out there? Kidding. It was a joke. Mo, I love you. Let's see. Abnormal behavior. So these are kind of some of the factors we can all think of when we think of mental health. We can describe all the outward signs, right? But there's a lot of things that we never even know. I mean, I kind of look at abnormal behavior. The one guy that comes to mind, and I know you guys probably aren't thinking it, but like Robin Williams. When you think of Robin Williams, what do you think? Really funny guy, really outgoing, likes to be the limelight, and yet he battled with depression, and no one ever knew anything. No one knew he had issues or nothing like that. So these guys, it doesn't always have to be that outward burst of emotional issues. These guys can be extremely quiet. These guys all of a sudden could be depressed one day, happy one day, and suicide happens. So things to think about. Organic causes of behavioral emergencies, altered mental status, and a change the way the person thinks or behaves. Again, when you start using substances or chemicals to try to make your mind right or even kill, again, when these guys are starting these medications, there is a therapeutic level that they have to reach. So when you read like about Zoloft and you read about those highs, and they have to get a certain therapeutic level for them to maintain. So you're going to see the high of highs. They're going to be whoop-de-doo all over the place. And then you'll see the lowest of lows where they're suicidal and depressed. They have to get that certain therapeutic level to where they can just maintain. So again, typically when we see these type of patients, they're usually the highs, they just started the medication, or lowest of lows, they stop taking their medication. So we're seeing those type of patients. Functional disorders. Etiology cannot be traced to obvious change in the actual structure of the physiological of the brain. The examples, psychiatric disorders include schizophrenia. Schizophrenia is a very tough. I look at it, people say, oh, I have schizophrenia. You'll be talking to them 1 minute and be left field, and they come right back. It's tough to say, especially personality disorder and those type of things. It's tough because are they medicated? Are they not medicated? Where are they at in their therapeutic regimen? They're a tough breed to figure out. Psychiatric signs and symptoms. Again, the reflection of the body is to maintain the balance. This is where, again, they battle with depression. They battle with stress every day. They're trying to hit that therapeutic threshold, but they might be high as high and low as low. So scene size up. So this is the tough part, I feel, kind of when it comes back what Pete talked about with medications and stuff. It all starts with information, right? So us as a crew, we go, we read our EMT book, we understand the processes, we understand medications, we have endless research at our tip of our fingers, right? We can look up all this stuff. The tough part is having that personal aware of walking into the scene, understanding, what's behind you, where we're at. So us as crews, we need to figure out who does what. Obviously we talk about the officer should do the whole scene situation, but sometimes you don't have that, you don't have those talks because you're so engaged. So I think scene size up is huge. And I think when we determine these things is not just because I'm a paramedic doesn't mean I see behavioral emergency like I have to be the guy. He might not like me because I'm a redhead. So pick your guy. Pick the person that needs to do what they want. I know I've gone on scenes where I felt like amped up. I'm amping up, the patient's amping up, and you have to stop and you have to reset. And maybe the next person has to do this. So read your scenes before you go into those things. I can honestly tell you, my worst scene I hate going on is drunks. I absolutely hate drunks. I was stabbed 10 years ago by one, and I'm just not down for them anymore. So, primary survey, a form of general impression. So, first consider your safety, obviously. These are kind of one of those things. So again, when you're dealing with behavioral patients, they're not going to tell you, hey, guess what? I have a knife in my back of my pocket. You're welcome. They're going to consider, they're going to lure you, help me. And they'll get you into they'll lure you into a safe situation where you think you're comfortable. But again, they're different. They're chemically imbalanced, and they're going to all of a sudden offset. I can tell you, I've been on schizophrenic patients, what something you said can cause the trip. the day that the guy decided to try to stab me was the one word that I said that tipped him off was like, hey, how about your uncle to pick you up? Because I knew him. I've been on this guy 100 times. But by me knowing a little bit about his personality and asking, hey, how's your uncle? Well, I didn't know that his uncle abused him for 50 years, you know? So these are kind of those things you don't know. The things you say or might say can trip these guys off. So understand your personal safety is very important. Determine how the patient is responding to the environment. Again, you know, are they postured like a cat, ready to fight? Are they kind of sad and woe is me? You know, these are the things we should never let our guard down. Assessing the level of danger. Again, posture is a huge one. Even our posture, us standing like this, it sends out a wrong vibe. When you stand like this and ask questions, what does that tell the patient? I don't care. I'm not here for you. And it's going to bring them into their level where they're going to probably wig out. Consider airway, breathing. Again, these are kind of all basic stuff, but ultimately, I always consider when I'm doing my survey is timeline. How long are we on scene with these guys? Where are we going? What is our end result? This is what we have to consider. Ultimately, we can spend an hour going in circles and going into their stuff, or we can decide, hey, wait a minute. Here's the fact. This is where we need to go. We're moving on. So, history taking. Investigate chief complaint. So, this is where I feel we fail as EMS is first going on, we go to these patients over and over. We're like, we know the problem and stuff. But this is where we have to, I think one of the best history, listen exactly what they want. Because sometimes they'll tell you different things that you're not listening for. Evaluate potential suicide. Again, those are kind of one of those things. Most people up front, I as a medic, I'm pretty blunt. I'm pretty blunt and honest, and you know, you got to ask those hard questions. You know, are you feeling suicidal? It's okay. You know, they may or may not tell you. You know, so just determine where they're at, and then always fall in your gut and try to get them help. History taking. So utilize surrounding people. Again, sometimes it takes a crew to get one patient into your ambulance to go to the hospital. Sometimes it's a matter of me expressing what I feel I want to say, and then I'm not getting it across, and maybe Scott comes up and Scott has a different way of talking and stuff. So that active listening, you know, be supportive, because you can have the people that look at you and then go from there. So yeah, you're welcome. Sorry, I'm sorry. Yeah. Go ahead.
So working at the hospital, I've seen that a lot, where they'll latch on to one person, and they can flip on a dime. But working at the hospital, I've seen this a lot, where one individual that they've been talking to for a while, they'll just get ramped up on that person, and all you have to do is just bring in a second person to talk to them, and that person will calm them right down. It's no rhyme or reason. It's just they're getting ramped. They've already latched on to you. You're now the enemy, and that other person that's the good cop. And yeah. It happens frequently. And then the other thing I was going to say was, I know we do it a lot on our shift, but when you're dealing with these, is to usually try to always transport with 2, maybe even sometimes 3, because if they're in a manic episode and they're going up and down, you just never know when they're going to flip. And I've seen it so often where all of a sudden you'll have somebody who's just laying almost comatose on a bed, and then within 30 seconds they're charging the door, angry, upset, swinging. Yeah. Or even just, we had a person try to exit the back of the ambulance on the freeway. And be restrained. And realistically, it takes 3 people to restrain someone. Just put them in restraints. 2 people can hold somebody down, but 3 to actually restrain. So yeah. Just something to think about when it comes to manpower. These things happen.
Hopefully you guys heard that. Scott made a really great point. You know, when we do have these patients and we're moving to transport, you know, bringing that second or third patient, he also talked about restraining. You know, it takes 3+ patients to restrain the patient. So these are great things to think about. It's not always like, well, let's just get them in the ambulance and then, our work's done. Again, the EMTs, the medics and stuff, we still have to our end goal is the hospital, but it doesn't even stop at the hospital. It stops when we go back in service. So make sure we're helping each other out. Thanks for that, Scott. And then documentation, I think this is where I'm not going to say we fail at, but like understanding why we're restraining the patient, that there's also a documentation piece that goes along with that. So how did you get to there? That's a big question we got to ask, and I'm sure once Pete comes out with CQI stuff, it'll be probably on our radar someday. Secondary assessment, physical examinations, look at the signs of the organic cause. Again, when you go on these patients, they might shut down, they don't want to talk to you. Medications, the perfect sample. When you start looking at medications, allergies, all those type of things, those are going to help you. Like, oh, this guy's schizophrenic. Oh, this guy has this issue. They're going to lead you to figure out what their cause is. Not all patients will tell you exactly what they want. They just called for help, and that's the first step. Remember, I have this thing, all patients lie. They can be 99-year-old lady, and they will tell you something totally different. So have that hunch. Everybody lies, and they're trying to get something from you, okay? So use monitoring devices to measure, assess oxygenation, circulatory status. Again, this is where, like when Pete was talking about our toxicology and stuff, we have to be diligent about doing vital signs. We have to assess the patient. Is checks matching the balances? If it's not, something's wrong. We have to change something. We have to move towards something. So if you see they're oxygenated at 80%, but they're warm, pink, and dry, what's going on, right? So is it our issue, their issue? So we got to figure out some things, okay? Interventions, reassess routinely performed during transport, monitoring patient vigil. Again, these are kind of one of those things I feel when you're dealing with these type of patients and stuff is open-ended questions, get them kind of talking about themselves, and then don't let them spiral into repetitiveness. Keep them forward, keep moving, keep them like, hey, what are you doing tomorrow? Project out there, keep them going versus living in the now. Communication, giving, receiving hospital advance warning. This is important. Scott, he worked as security at KMC, but having that good relationship with security is nice, because when you come into a situation, you're like, help, it's nice that they're ready. I feel KMC, out of all the hospitals I've been through, all the security is great. They're right there. When they hear something coming, they're ready to go. So again, it comes back to documentation. If restraints are used, say what types. I know we got on our documentation, and there is a little tab, but make sure you understand why they are, because it's just it's interpretation, right? Well, I was scared, but what led you to restrain this patient? I know probably in the ED, it's a lot of paperwork to say, hey, I handcuffed this patient, or hey, I physically restrained him because of this. Now we're talking about medics chemically sedating patients. How do we get there? We have to document. So let's see, emergency medical care, maintain safety. Again, foremost, your patient, try to make them safe as possible. And then, of course, you're number one. Make sure, and then your patient and stuff, or your partner. Place the patient on a stretcher with straps in place. Again, I know Chief Isaacson has hit this a couple times. I'm just going to reiterate it, but we have to be using full straps, full chest harnesses. We got to make sure safety is key. Remain with the patient at all times. Again, seems like there's times where probably, people, this is the big thing. When a patient decides to destroy your ambulance, do you stay in the ambulance? No, unless it's moving, right? So there's some things to consider. But again, the ambulance is whatever. Us is priority. So understand that, engaging in these people, we should just try to avoid and get away. Avoid challenging the patient's personal space again. That's what I'm saying. If you have issues and stuff, again, I know we're in the alpha male business and stuff, but these you don't know what these guys can do. Avoid being judgmental. It's easy after a few years into the system to get kind of like, oh, I've seen this. Oh, I've been on this guy. Oh, look at this guy's house. It's easy to kind of, but understand these patients are in a time of crisis, and try to put your best foot forward. Acute psychosis, again, is a state of delusion in which a person is out of touch with reality. These are really the ones that are tough to try to help. Usually you just saying, hey, walk this way, they don't understand that. They're in their own world. I know I've been on calls. I'll bring up Captain Hall. We had a guy in state of delusion where he was basically regurgitating the Bible and just like this. And I remember Captain Holland Street talking to this guy, and they were saying the Lord's Prayer over and over again. The guy had no idea. So we sedated him, got him safely to the hospital. 3 hours later, he goes, what are you talking about? He didn't remember anything of it. So these are kind of those tough patients where try to engage them, it's not going to help. So again, try to be safe, try to move the patient along and stuff, and then they ultimately extended care. Let's see, schizophrenia. Okay, so schizophrenia. Again, we kind of hit that on the earlier part, but these are kind of, again, these patients are tough. They're tough to read. You never know what's going on. They could be happy at one point, angry at the next point, sad. I mean, they're just kind of all over, depending on where they are in their medication, depending on where they are in their treatment, if they had any treatment. So delusions, hallucinations, lack of interest and pleasure. I mean, these are kind of those patients that are really tough to just be around. Assessment of psychosis. Again, these are kind of, I don't know what post-map mnemonic is. I'd have to, do you have that in your book? Patients are usually incoherent or rambling in their speech, although examination patient is rarely possible. So these are kind of one of those things when you look at these patients and you see they're in this psychosis, trying to get information is going to be tough. So this is where we have to rely on what we're seeing outside. You know, what physical findings are we seeing? Are we seeing trauma? Are we seeing, what is our assessment showing? Transport the patient to the hospital, again, these are kind of one of these patients where we have to try to get them to follow us and then move along. So there's an acronym, COAST map. And the first one is consciousness. The patient is awake and alert, oriented or orientation. Disturbance in orientation are more common or organic disorders. The activity is most common in accelerated or agitation, hypersensitive or hyperactivity. Speech may be pleasure of sound strange because unusual words. Patient has been invented. I've had these type of patients in a psychosis where I had this guy that was off his lithium. He just kept on repetitive, and every time he looked at me, he asked me if I was Jesus. You know, and the part of me that likes to be smart and have fun with yes, but no, we have to keep professional and stuff. So these guys will repeat speech. Thought is disturbed as progression, and content may show as the following disorders: so fight or flight, loosening associations, thought broadcasting, thought insertion, and thought withdrawals. So just remember these patients have like 50 million thoughts go through their heads, and they might act upon some. They might just blurt out things. You never know what they have. Memory. They entirely intact with psychosis. It may be difficult, so they might not understand where they are, or they might revert back to a certain time in their life. Affected mood. Again, these guys are purely affected by the surroundings and what aggravates them. Perception. Auditory hallucinations are common psychosis. People hear voices. There's things where they can get on there, they hear different things. Again, these patients are extremely tough to dive into, and none of us really have a psychologist degree, unless Keely's listening. So, but he might help. So, management, again, usually methods of reasoning with the patient is unlikely. Again, you're going to go in this circle where you try to things and it's not going to work. So have open-ended questions, continue to go, and then ultimately try to get them to a safe place. Directions should be simple, consent, and firm. Again, this is where we're going. This is what we want to do. Closed-ended questions, not open-ended. And then move them along. And then if they start to dive off into a rabbit hole, keep them, say, this is where we're going, this is where we're heading. Suicide. Suicide is kind of a really all kind of, it's just a blanket statement, I feel. I mean, there's all kinds of different types of suicide, why they want to do it, what happened, warning signs, all these things. Sometimes we find we don't know, you know. Ultimately, we associate suicide with depression. It's the most significant factor that contributes to suicide. Common misconception, people who are threatened by suicide never commit it. Again, you never know what people are thinking. You never know what's going on in their life. You never know the highs. I can honestly tell you, when I've had a few of my friends die from suicide, and I never knew they wanted to commit suicide until afterwards. When the day before they did it, they were happy. They were just relieved. Everything was okay, perfect. This is where I'm going. This is where I'm heading. And it wasn't. I've always thought it was selfish and stuff like that, but in their mind, they don't see it as that. They see it as a relief. I'm going to relieve myself from Scott, you know, because Scott is like, you know, worried about me, and I don't want him to worry about me anymore. I'm going to take my life, kind of thing. So that's what these people think. So I don't want to, Scott. So I want to hang out. So a suicidal patient may be homicidal as well. Again, you never know what these people are thinking. Agitated delirium. Again, these are kind of those patients where scene safe, BSI, all those things come into play. You probably know, you guys could probably name 10 patients you've been on that have had this. This is your approach: safe, calm, supportive manner. Sometimes we try to limit that, but try to limit the physical, you know, contact. And these are the ones where, unfortunately, law enforcement has to come in to play, you know. And then they tactfully try to mitigate it, and then we try to slow the roll. Medics, we can chemically sedate and stuff. You're kind of tied as an EMT advanced. This is something where I think you should have the medics be coming and stuff and trying to just ease the playing field. We do have medications to help with that agitated delirium. Mood disorders, again, you can make a blanket statement. There's a lot of people out here with mood disorders, especially if they don't have coffee or they're monsters. Just kidding. So the changes in effect are accompanied by other symptoms, and that effect to the cause majority disturbance of the patient's ability to function. Again, these type, you know, they say they're bipolar or unipolar or whatever. These type of patients purely depend on what mood they're in. So if they want to hang out, they want to hang out. If they want to fight, they want to fight. If they want to just cry, they cry. So you never know what you're going to get into. Ultimately, depression is usually kind of the big one. These patients, you might not even know they have a disorder. So, you know. Neurotic disorders. So treating neurotic disorders comes with substantial price. Anxiety disorders. Again, I feel anxiety is kind of a blanket statement. There's so many disorders and stuff, and moods and the way people go. You know, there's a lot of medications out there to help with general anxiety. I think a lot of people kind of pass over, oh, it's just an anxiety attack. But until you experience that type of disorder or been involved, I mean, I can tell you I've had one panic attack, and I had no clue what to do. Like, I was a medic for 5 years, and I've seen millions of anxiety attacks, and here I'm having one. I thought I was going to have a heart attack, you know? So, I mean, you don't know. So just consider, ultimately, I found for me it was counseling. Counseling really helped me with some issues I had. So Phobic disorders involve unreasonable fear. Again, I've been on a lot of patients that have been on where they don't like to go outside. They're scared. I have a phobia of the sun. I don't like to be sunburned. It's a joke. We got 2 people laughing, so if anyone's listening. So, so panic disorders, again, characterized by sudden, usual, unexpected, overwhelming fear, feelings of fear, dread. Again, a lot of people have different types of disorders. They take different type of medications, and like I said, when you start taking those medications, you have to get in that therapeutic threshold, or you're going to have the highest of highs and the lowest of lows. And these are the panic disorders. These are the patients most of the time you'll see when they're trying to titrate their medications. Medicological considerations. Again, this is the tough part we play in. Pete talked about in the toxicology. We kind of brushed over it, but alcoholism, this is the tough part. You have the 46-year-old drunk that's been drinking for the last 15 years, totally fine. You think he's fine. Oh, it's just Larry, he's drunk again, right? Sitting on the bar stool, he slips off, he falls, strikes his head, gets back up. We kind of look at him, it's just Larry, he's drunk. Send him on home, 3-4 hours, dead, right? He had a brain bleed. Well, why? Well, in the toxicology, we think about how alcohol can thin the blood sometimes. And then when you have an organic disease of alcoholism, it shrinks the brain and stuff. So you're more susceptible to brain bleeds. So these are where us as assessment, we have to assess these patients. We have to take in consideration like, do they go, do they not? If they're having those type of crises, they need to seek some help. Mental incapacity can take many forms. Again, we kind of work on the law, consent, non-consent, all those kind of things. Unresponsive, that's pretty easy. They're unresponsive, we're taking them. Temporary but severe stress. This is kind of one of those things. I think you hit one of those mood disorders where they're in that panic mode, and then a couple hours they just figure some things out, have some conversations, or medication kind of levels them out, puts them back into the game. This is tough. I mean, do we trust those patients that they're going to work out, or they're going to work out a different way? So when we're taking these patients, we got to consider that stuff. And ultimately, depression. Depression, again, encompasses, there's so many different types of depression, where they're at, how they feeling. I can tell you that most people, I got to wake up, I got to go to work, I got bills, I got this. There's many types of forms of depression. So consent, we'll hit this a little bit. Implied consent, obviously, assume the patient who is not mentally competent to grant consent. So these are kind of one of those things. You can talk about pediatrics and stuff. When you go on patients, a kid has a broken arm, you can assume that the parent's going to say, yes, I would like him to go to the hospital. So it's implied that we take these. Under non-threatening situations, emergency medical care, transportation may be delayed until proper consent is obtained. This one's a little tough one. This is where law enforcement needs to come in with us, and you need to have these conversations. I know as a medic, I sit and have a lot of conversations with law enforcement about what are the legal rights. Can you put them on a medical hold? What does that encompass? Can these, and most of the time the law enforcement says we can't really take them under because they're mentally capable. It is what it is. So this is kind of one of those things where our hands can be tied to where we might not be able to treat these patients. So make sure to get that one. Make sure to get law enforcement involved. Make sure that you guys have a good game plan, and then try to reason with them. Contact medical control, that's always a great one. In all honesty, the times I've contacted medical control, it's tough. The doctor has to make a decision by what you say. So how well you explain the situation is how well you're going to get the answer. I can tell you by mine and Pete, probably the same way, we like to put a big old carrot in front of the doctor, so we lure them the way we want them, or steer them the way we want to go. So if you have a good idea where you want to go, I would try to steer it the way you want it. Because I would say most doctors aren't going to be like, oh, you want to use ketamine and do all this stuff, date the guy? Well, oh, okay. Well, they don't really buy into that. But if you lure them and tell them this is where we're at, they're like, oh yeah, well, let's be safe about it. So patients have the right to refuse care. Again, as long as they're in sound mind, not impaired, you can make those rational decisions. If they want to go lay on the side of the road and die, that's their problem. This is, again, where we get law enforcement involved, make sure we understand laws and what we can and cannot do. But again, they have a right to refuse. That's okay. Again, a competent adult has the right to refuse treatment, even if life-saving care is involved. Again, it's their choice. So, but it also into right here when police control. Again, this is where I would err on caution with the police. They have more, because usually there'll be a sergeant. He'll call the DA. The DA will be like, "Yeah, boom," and so they'll be right on. They'll figure out some stuff, and they can some loophole to get them. So that was good. Err on the side. Restraints. Again, we kind of hit the medical restraints, but must be ordered by a physician, court order, or law enforcement officer. Like for us, it's more an SOP. It's a safety issue. That's probably my phone. Sorry. It's more of a safety issue and stuff, and so we do have SOPs. So I don't want to say KCFR SOP because this is a National Registry class, but kind of go through, make sure you understand what you can and cannot do with our restraints, and make sure the huge thing I recommend is documentation. If you're going to use those, make sure you understand what you need to document. Legal actions can involve charges. So this is kind of the scary thing for us. If you decide to restrain a patient that didn't want to be restrained and you didn't do very good at documentation, you can be liable for assault, battery, false imprisonment, or violation. Again, they have to prove all those things, and we use due regard, right? Or do no harm. So think about these things. This is where documentation is huge. And like Scott was saying, second or third, now we have videotapes and stuff, but have those witnesses and make sure you guys can validate. Restraints, again, this is kind of what we I've hit that. PTSD, sorry. Again, we're kind of learning with one of our captains. He went through kind of his thing with PTSD. We have some guys that have been to war. I mean, all of us are effective in some way or somehow. So it's just basically a reaction that could to trauma that occur over a long time ago. I mean, anything can trigger us, or what the overexposure we see every day, just life situations, how we grew up, those kind of stuff. There's a lot of, it's just a disorder. You're just overstressed. Signs and symptoms: feeling of helplessness, anxiety, anger, and fear, nervous system arousal. Again, these are kind of one of those things that you need to take charge and progress and have end in sight. Signs and symptoms: so increased heart rate, dilated pupils, systolic blood pressure increases, sense sharpened, the mental acuity is heightened. All right. Guilt, shame, paranoia, hostility are not common.
Dude,
but
thank you so much.
You're welcome, Chief. Take care. Yeah. So again, they say not common: guilt, shame, paranoia, hostility. Again, everybody's different. Everybody takes stress certain ways. Everyone handles stuff. So don't feel like they're paranoid. It's not PTSD. I mean, it just depends on what type of disorder they have. So take those two in effect. Again, treat everyone same. Return combat vets. I feel like right now it's becoming, we're probably early in my career, we didn't have too much returning combat vets, but now we're starting to see it frequently, to where we have guys on our departments that have served in combat, and they have, whether they know it or not, they may or may not have issues that they haven't even resolved yet. I mean, I can honestly say when I worked over in Spokane, you know, any type of fireworks, those kind of stuff, I've had a couple of my partners, they would wig out and have some issues. So you never know what's going to set these guys off. So, Sam, I'm looking at you. I'm kidding. Kaipo, you know the joke. All right. Take time to establish the history of the patient. Again, this is where I think we fall short, is becoming great listeners. Sometimes it just takes a little bit of time to sit and talk, make sure we understand what they're going through, make sure we acknowledge what they're going through, and then go, whether or not you've been to combat, whether or not, I mean, I have no concept of war. I've never been in the military, but you know, we see it, we see the toll it takes on there. It's devastating. So have that compassion, understand what they're going through. Approach the patient with sensitivity and respect. Again, it kind of goes on with there. And be careful how you phrase questions. That's the really tough. I think if you don't take anything from this lecture, is be careful how you question or how you phrase your questions, because communication is very key on these patients. Just like that, 15 minutes. Thanks, guys. You guys are awesome. Any questions? So I just hit that.